Yes, good to start.
Hello and welcome to Yashoda Hospitals. I'm Pratisha Chowdhury, hosting Nursing Education and Training webinar series live on Facebook every Thursday at 3 p.m., bringing forth the most interesting topics. And again, thank you for joining us today. Stay tuned till the end for the expert discussion. Also, you can post your queries and questions in the chat section, which can be addressed at the end of the webinar. So, whenever we talk about the neurological patients, we do have many questions how to assess GCS of a patient. Not only GCS, we need to also analyze the pupillary reactions. With furthermore interesting things in assessing the neurological patients, we have brought you the topic for today is assessment of patients in neurocare units. Without further delay, I just wanted to introduce you to the pros of today's webinar. Uh, I take the privilege of welcoming our expert panelist for the day, Dr. Sai Satish Sir, Senior Consultant Neurologist and Epileptologist, Yashoda Hospital, Secunderabad. Looking forward for your valuable input, sir. I'm happy to introduce our speaker for the day, Ms. Rosalind, Nurse Educator, Yashoda Hospitals. So welcome, Rosalind. We hope you will brief us about all the neurological uh, terms and conditions which needs to be followed for the nurses especially. Over to you.
So thank you, Ms. Pratyusha. Okay. Thank you all for joining us. Then coming to the next part, where you check the. Okay, so assessment is the first and initial step, also the important step when we want to diagnose and treat a patient effectively. So today we would be discussing about the neurological assessment. Initially, we would talk about the super 3 components of neurological assessments for patients in the neurocare units, indications for neurological assessment, observation and analyzing the condition of a neuro patient using GCS and also the pupillary reflexes. We would also pay a small attention on the assessment on patients with EVD, that's external ventricular drainage. So what are the indications? In which patients do we do a continuous neurological assessment is, first, when there is an altered state of consciousness, including coma. Next is cognitive decline, when you see signs of confusion, disorientation, blurred or double vision. Okay, when the patient complains of blurred vision, we understand that there is something wrong with the brain and its functioning. Then impaired hearing. Okay, any kind of sensory loss is also connected. Then loss of smell, change in balance or coordination, numbness or tingling. So these are the indications which will tell us that there is something wrong and we would like have to do a neurological assessment for the patient. So here in my webinar, we will be discussing about the super 3 components of neurological assessment. Okay, so the first among the super 3 component is the general observation of the patient. We do a head-to-foot examination and do a general observation of the patient. Then NIHSS stroke scale, AVPU, GCS, which we will be discussing in the further slides, and pupillary assessment. So these 3 are considered to be the super 3 components of neurological assessment. The first one is general observation. In general observation, we will be talking initially about the ABC assessment. ABC talks about airway, breathing, and circulation. In airway, we will have to check if the airway is patent or there is any obstruction. Are there any sounds? Do you hear any abnormal noises when the patient is breathing? Then breathing also, any abnormal sounds like crackles, wheeze. And then you will see if the patient is into labored breathing. Is he using any of his accessory muscles while breathing? Is he into distress, tachypnea and all? Then circulation, we check the temperature, we check pallor, we check the refill time to assess that the circulatory function is good. Then vital signs are the vital part or vital component of any assessment. Spontaneous motor behavior of all the four limbs. When we talk about motor response, we see if there is proper coordination, we see the gait and balance. Okay, we also see the symmetry, bilateral symmetry, whether both the sides or both the limbs, the patient is moving symmetrically or not. Then we talk about oropharyngeal reflexes like coughing reflex, swallowing, hiccuping, yawning. Then also we see any signs of trauma, an external scar, bleeding, or post-op drainage and catheters. In post-op drainage and catheters, I would like to highlight the EVD, external ventricular drain. So when patients are in the post-op period, apart from checking the scar, apart from checking the dressing, the surgical dressing, whether the sutures are intact, there's any gaping. Other than that, when the patient is on EVD, we must make sure that the transducer is placed at the external auditory meatus. Then the oscillation in the column. This is important to know if there is any obstruction. Then the head dressing, whether it's dry and intact. Then the status of the drain, if it is clamped or unclamped. CSF appearance, what is draining out, what is the color. Then the patient position should be preferably head end elevation should be done for 30 degrees. Zeroing to be done after every repositioning. Every time we reposition the patient for any reason, zeroing should be done. Then hourly documentation is important. Coming to the NIH stroke scale, this is National Institutes of Health stroke scale. It has 11 components like level of consciousness, the questions asked, LOC commands, best gaze, visual fields, facial paresis, motor arm left and right, motor leg left and right, limb ataxia, sensory, best language, dysarthria, extension and inattention. Okay, the score is taken from 0 to 42. 0 is when there are no symptoms of stroke. 0 to 4 is given when it is minor stroke. 5 to 15 talks about moderate stroke. 16 to 20, moderate to severe. 21 to 42 is severe stroke. So as the score increases, greater is the severity. The next scale that we usually follow is the AVPU scale for the level of consciousness. A, when the patient is completely alert, awake, and interacting normally with the environment. So he's completely oriented. Verbal stimuli is he is not alert, but responding to verbal stimuli. Painful stimuli, he does not respond to voice, but he responds to painful stimuli. What are the different kinds of painful stimuli? We would be learning in the next slide. Unresponsive does not respond to any stimuli. Whether you call him, whether you give him any pain, the patient does not respond. So the next scale, the most important and the common scale used for neurological assessment is the Glasgow Coma scale. Okay, it has 3 components, as we all know. The first one is eye opening. Second one is verbal response. The third is motor response. So eye response, the highest score is 4. The minimum score is 1. If the patient is opening his eyes spontaneously, he's opening on his own, he's closing on his own occasionally, it is E4. If he's responding to your voice, then it is 3. Painful stimuli, E2. No response at all is E1. So when we talk about painful stimuli, the common stimuli that you can give to a patient is nail bed pressure, as you see in the image here. You have to give slight pressure on the nail beds and see if the patient has any response. Or you can give a trapezius squeeze or the supraorbital pressure. If the patient is responding to any of these stimuli, you can give him a score of E2. If there is no response at all, it is E1. But an alert again, there can be a condition as seen in the picture where you cannot assess the response of the eye. Like if the patient has swollen eyes, any traumatic injury. So in this case, you have to write non-testable. Coming to the next aspect, verbal response. Okay, so the mnemonic you remember kindly, it is ESPN. E for eye opening, spontaneous, S for speech, P for painful stimuli, N for no response. Next is verbal response. The mnemonic we can remember is our country win. O for oriented. He is oriented to time, place, and person. We give him a score of V5. If the patient is confused, he's talking, but it is not quite relevant to the situation, it is V4. He's able to use words, but they are not appropriate. They are not complete in sentence. They do not convey a complete meaning. So it is V3. He cannot speak even a word, but he groans or he moans. He makes some kind of incomprehensible sound, then it is V2. No response at all, V1. Okay. Again, in this scenario, in patients who are intubated, who are on ET tube, they cannot talk. So we will write it as VT. It is non-testable, or verbal response tube, T, if they are on ET tube. The third aspect is motor response. The mnemonic we can remember is can't live without fans. Okay. The first is commands obeyed. You give him a command to move the hand, to move the leg, okay, nod the head. If they're following the commands, then it is M6. If the patient is able to localize pain, you give him a painful stimuli and he's able to bring his arm to the site of painful stimuli, then it is M5. Withdrawal to pain is a normal flexion attitude that the patient can show by moving the arm, withdrawing the arm. Next is flexion abnormal. This is called decorticating posture. You will give M3. Then abnormal extension is M2. It is also known as decerebrating posture. No response, M1. This is clearly depicted in the picture that is displayed. Patient is able to localize pain, M5. Withdrawal flexion is M4. Abnormal flexion, M3. Abnormal extension is M2. So these are the three components of Glasgow Coma Scale: eye response, verbal response, and motor response. When you have a situation where you cannot test, you can just write it as not testable. So the total score is 15. That is 6 plus 5 plus 4, it is 16. So the best response for any normal individual is 15, whose brain functioning is intact. Then 8 or less is categorized as comatose client. A totally unresponsive patient will fall under the category of 3. Score would be 3. So this is the overall score for a patient in GCS. Coming to the pupillary reactions. Okay. Pupillary reactions, normal pupillary response is depicted as PERLA, P-E-R-R-L-A. Okay, P for pupils, E for equal. Okay, so both the sides, when you focus the light, the reaction of the pupil should be the same. It should be equal. Okay, and the normal shape of the pupil is always round. So pupils equal, round, whether they are reacting to light. A normal reaction to light is always constriction and accommodation. Okay, when you focus the light onto one eye, the other eye also tries to accommodate it. So how is the accommodation? So normal pupillary reaction when documented would be pupils equal, round, reacting to light, and accommodation. So coming to the abnormal pupillary reaction, if you see in the picture, the one on the right is bigger than the left. So this is unequal size. This is an abnormal reaction. When you see the next image, it is not round. Then it has no reaction to light. Okay. And then it is not accommodating an object that is far. So these are some abnormal responses of the pupil. So the abnormal or unreactive pupils are also scored, given a score. Okay. If both the pupils are unreacted, you give a score of 2. If one pupil is not reactive, it is 1. Normal is 0. Okay. Now, if there is reaction, you give a score of 0. So there is a modified GCS score called GCSP, which includes pupillary score. So if the pupillary score is 2, for example, and the GCS score is 13. So GCS P will be 13 minus 2, that is 11. Clear? If it's clear, then we'll go to some of the scenarios. Okay. So scenario number 1, I have displayed the GCS for your easy access. A 45-year-old male patient is brought to the casualty following a road traffic accident. Okay. He is opening his eyes to painful stimulus. When asked for name, he was repeatedly uttering some words. Okay. Same words. On stimulation, his limb shows normal flexion attitude. So what would his GCS be? You can answer in the chat section. He opens his eyes to painful stimuli. Okay, we have already displayed. So the eye response would be E2. Okay, because he's responding to painful stimuli. Then when asked for name, he's repeatedly uttering the same words. Okay, he's not able to form any sentence, but he is using words. So it is words inappropriate. Last one is he shows normal flexion attitude when stimulated. Okay, so that is he is withdrawing to pain. So the score would be E2, V3 and M4. I hope everyone's got correct on that. Going to the next scenario, a 50-year-old male patient is brought to the casualty after a fall at home. He opens and closes his eyes on his own. He is completely oriented and moves all the 4 extremities as instructed. So what will the GCS be? Okay, he had a fall at home, but he opens and closes his eyes on his own. That is, spontaneously he's opening his eyes. So the score would be E4. Now he's completely oriented. You ask him about name, time, place, any question, the answer is right. So he is oriented. That's V5. And the last one, he moves all the 4 limbs as instructed. Okay, so he's obeying our commands. So that's M6. So the score would be E4, V5 and M6. And the total is 15. Then a 26-year-old female patient is brought to casualty suspected of drug overdose. She does not open her eyes even to painful stimulus, but moans loudly and shows abnormal extension when stimulated. What will her GCS be? Okay, so she does not open her eyes even to painful stimulus. Okay, when she is not opening the eyes even to painful stimulus, then it is considered to be no response. Okay, then she moans loudly. There are no words, absolutely no words, but she is making some incomprehensible sounds. So that's V2. And then she shows abnormal extension when stimulated. She's showing a decerebrating posture. So that would become M2. Okay. So the score is E1, V2 and M2. Okay. So to revise, we have been discussing about neurological assessment, okay, stressing more upon GCS and pupillary assessment. Okay, GCS, we have eye response, verbal response, motor response. So the top score or the best score is 15. Okay, so in traumatic brain injury, they score it as 13 to 15 is considered to be mild injury. Okay, 9 to 12 is moderate. Anything 8 or less than 8 is considered to be severe brain injury. And also, I would like to highlight a point is in patients where you cannot assess using GCS, there is another scale called the 4 score in which the eye response, motor response, brainstem reflexes, and respiration of the patient are considered. Thank you all.
Thank you so much, Rosalind. That was an amazing presentation that you have given, a complete detail about the GCS and the pupillary reactions, and you have given us the very interactive scenarios. Thank you so much for that. And the panel is now open for the discussion. I request all the participants to post your questions in the chat section so that we can address it. And apart from this, let us also welcome our expert panelist, Dr. Sai Satish sir, onto the board, so that we can discuss much in detail about the neuro patient care.
Thank you. That was a very nice and crisp talk by Rosaline. I would appreciate that. And few points I would like to add. One, while assessing the neurological status, one thing is the language what the patient knows is very important. So sometimes people, maybe the person who is intubated might be knowing Hindi or Malayalam, but if he's in our native language, if he asks, he might not respond to that. So sometimes that might be a confounding factor. So we need to ask what languages the person knows, and depending on that, we need to ask him to like open the eye, move the limbs, or answer to our questions. And this other thing is like rightly Rosaline has suggested that we need to examine all 4 limbs. Okay, not only one limb. You need to give painful stimulus both proximally and distally in the upper limb, proximally and distally in the lower limb. And what we need to see is for the symmetry. Is he withdrawing the limbs equally on both sides, or is there any symmetry? That's very important. That gives us a kind of information regarding which side of the brain are we dealing with. Okay, and the other one is, though at one point when we do a neurological examination, it gives us a baseline.
Yes.
However, the serial examination gives us their progression. That is very much important. So we need to document that. So we need to document and keep looking at the trend, like how is the GCS improving, or is it same, or is it worsening or not. And some subtle scenarios where Rosaline has said, by looking at eye response, if someone has periorbital edema, where you cannot look at the eye response.
It's not testable.
No. In the similar way, someone is tubed, but they are wide awake, they'll not be able to talk, but they can write sometimes.
Yes.
So the output in the language can be in 2 types. One, they can actually speak. Other is write. So someone who is tubed, but if you feel they are awake and alert, you can actually give a pen and ask them to write, or even actually point at some object and ask them to name them. Like you can give, like show an apple figure, you can give apple and orange, they can point at which is apple and orange. So in that way, we can actually fine tune.
So we can consider that as oriented, sir?
Oh yes, why not? Yeah, let us someone who is tubed, we show an apple and we write apple and orange, 2 options. If he points towards the apple, which is the correct answer, we can actually give it as V5.
Yes.
Okay. And other thing is accommodation, which you have said in the pupillary refraction. Accommodation is what we look at is we actually ask a person to look at something far away, put one object very near, and suddenly ask them to concentrate on the near object. So we look at the adduction of both eyes there and the pupillary changes. So these are the few points which I would like to add, but overall it was a good presentation, very lucid presentation. Congratulations.
So one more question from the participants. Deepthi is asking a question. What is the exact difference between withdrawal pain and localizing pain? People do confuse a lot between these two in the motor response. So what is the difference between these two?
True. Withdrawal pain is where the person withdraws the limb away from the painful stimulus. Let's say someone is giving some noxious stimulus, right index finger nail bed. So if they are withdrawing from that, we call it as withdrawal reflex.
Yeah.
Okay. So in order to see if it is a localizing pain, we can actually give the painful stimulus in the midline, either in the supraorbital region or the sternum, where the so-called normal side, they'll usually try to localize the pain and try to take out our hand
Yes.
if they have reasonably good power. So this is considered localizing pain. In people, let us say, who has right hemiplegia, where their right upper limb and lower limb are weak, and we are trying to give a painful stimulus in the right index finger nail bed. So if at all there is a localization response, they might actually take their left hand and take it to the right index finger where the painful stimulus is being given. That we can take in as localization.
Yeah.
Or if there is no response with the left, but the right upper limb only he's trying to withdraw, that is withdrawal.
So one more question. We commonly see one important thing when we do IV cannulation. People should not think it as like when the patient is trying to pull it back, it wouldn't be considered as a like localizing the pain or withdrawal to pain.
Yeah, we can definitely consider it. Sometimes when you're decannulating, definitely it's a subtle, painful procedure. Yeah, if someone is actually trying to localize and giving her, trying to take out her hand or pulling out the tube, yes, we can take it as localization sign. Definitely, we can take it.
For the same, I was asking for the IV cannulation, sir.
Yeah.
Because most of the time we get the questions from the nurses like if I'm trying to keep an IV cannula for a patient and suddenly the patient is trying to pull his hand back. So would that be considered as a motor response?
Oh yes, why not? That's a withdrawal response, classical withdrawal response. So what we look at GCS also is the best motor score. What's the best motor score? What is the best verbal response? What's the best eye response?
So what would be the best motor score for this, sir, when the patient is withdrawing from the...
It will be M4, at least M4. Because since we are putting an IV, placing an IV cannula, he is trying to withdraw.
Yes.
Let us say that is at least M4. But if the same patient, after placing an IV cannula, if we had put some supraorbital pressure with the same hand, if he is localizing, then it would be M5. So that particular point of time where we are placing an IV cannula and the patient is trying to pull the hand, we can say that it is at least M4.
But we should not consider it as abnormal, but it should be a normal response, motor response from the patient side.
True.
Yeah. Great, sir. Sir, one more question that we wanted to talk about. What are the other type of scales that we can use for neurological assessments apart from this GCS or GCSP, which we have discussed during Rosalind's presentation? Apart from this, do we have any other scales?
So there are many scales actually. Apache score is there where you look at the overall status of patient, which includes not only GCS, it includes all other parameters as well, including the body temperature and hemodynamics and all. That can be taken. And however, though like many scales are available, GCS is very widely followed and it's very simple to use.
Yes.
There are only 3 components in that. So rather than like looking at various other scores, this is one way where many people in the medical fraternity are aware of it. So communicating in that score would be even more easy. Apache score, you need to take a very big chart, jot on everything, add it and say. So I think this is very practical and useful score, GCS.
So we heard about the 4 score where we talk about the cortical stimuli, all this. Do we need to really teach the nurses about this 4 score?
I don't really think so. This is like GCS is the best one. Yeah.
If you want to detail us about head-to-toe assessment of a neurological patient, what would be the focused points? So
it all depends upon the clinical history. That's the main thing. Head-to-toe examination, especially neurological thing, is a very, I would say, laborious process. Okay. But if we are focused, then we can do like tailor it to whatever it's required. Okay, so if let us say, for example, some person has presented with fever, headache, and now and altered sensorium, we would like to see one their the pupils, eye movement. Okay, and more important, looking at the movement of the limbs also. In addition to that, we need to look for the meningeal signs, since we know, okay, we are reading probable meningitis. Okay, similarly, let us say we have some person who has sudden onset weakness of left upper and lower limb. There we go for NIHS scoring.
Yes.
Okay, so it's all depends upon the history, what the person has
Patient
presented
is.
with. Yeah.
So what would be the take-home message for the nurses, the nursing fraternity that you wanted to give about the assessment of patients in neuro care units?
In a gist, if I want to say, one, before neurological assessment, we need to make sure what language the person understands. That's most important. And second thing, we need to know the history. Many of the time, usually they are not aware of the history, or sometimes the probable diagnosis and all. So we need to be sure about these two. Then we can actually focusedly monitor and examine what is actually required. So that is my take home message. GCS is very practical, easy tool to learn. And that is an easy way to communicate to the other people of our medical fraternity. Yeah, these are the two things: language of the patient, knowing the diagnosis, and most important, I think many of the times nursing staff, they might shy away from discussing their findings with the consultant or the treating doctor. That
That's
discussion
really
is
true,
very,
sir.
yeah, so
Really true.
that is very much important. You need to discuss so that you can corroborate your findings with them. And if possible, many a times, though they might be busy, but if you ask them to explain, that should not be a problem. It hardly takes them 1 minute, so you can clarify your doubts, and you can actually involve more in a patient's care when you know like what to look for and when to alert the treating physician. Okay, so in that way, knowing the diagnosis, you have your own assessment. When the doctor comes, you can actually discuss with your findings with them, corroborate, and you can ask them like what to look for. Or you can tell that, sir, these are the findings I have seen, this is what I would like to monitor, is there anything which I should monitor? In that way, like as a team, whole of us can involve in the better patient care.
Thank you so much, sir. It was an amazing discussion that you made in crisp. Also, Rosalind, that was an amazing presentation that you have made it. Thank you so much, everyone. That's for today about the assessment of patients in neurocare units. I've just wanted to mention upcoming next coming webinar is completely about the International Pro Nursing Quiz. So please don't miss it. And for that, we have the registrations and we have a prize money, which is of 10,000, which we are making it into two big rounds. One will be held on 15th and the other will be held on 5th of January. So 15, please don't miss. In case if you want to participate, we have a registration link, which you have to just come into the Yashoda Facebook page, and then you have to just register yourself for that. Make sure you would definitely come in and do win the prize for your own organization. There is no limit for the registrations. Please do register for yourself, and this would be really exciting. And we also will come up with more informative sessions like this. Thank you, everyone.